on this computer. We did it. I figured out how to record. Okay. Well, welcome. All right. So this is intended to be a 30-minute conversation between me and you. I have some questions that patients submitted, and so we have a list that I want to make sure we're going to answer. But of course, we want to talk about just like the general things about high blood pressure. So I'd like to introduce everybody. Welcome to Tuesdays with Dr. T. I am your podiatrist, and now I'm a podcaster. Hey, look at that. So I wanted to put together information with people who are experts in their field. And I'm no expert at blood pressure whatsoever, but I do work in conjunction with a lot of doctors as it pertains to surgery, because we always have to request that surgical clearance and ensure patients are optimally in good shape before any surgical procedure. But we're going to talk a lot about more practical things on why hypertension is important. And I want to introduce to you our special guest, Dr. Is it Adalola Ashaye? Did
That's
I do
right.
it?
Yes.
Perfect. So I don't think I can introduce you any better than you can introduce yourself. So please welcome, introduce yourself. How would you like to be known professionally and personally?
Awesome. Thank you, Dr. T. Thank you for having me. I'm really excited about this topic. I'm a primary care doctor, a family doctor based in Houston, in a Houston suburb, Sugar Land, Texas. And I'm the CEO of In Touch Primary Care. And I have been a physician for 15 years and married to my wonderful husband. We have 3 little kids, including twin girls and a little boy. So that's a little bit about me.
Do your children know that you're a doctor, and do they aspire to that?
So they know I'm a doctor. They change their mind every day about what they want to do.
That's fair. I think we do too as adults anyway, right?
Exactly.
All right, let's get right into it. So blood pressure, hypertension is the medical term. Why should anybody care? Like, what is the implications of high blood pressure? What's important about it?
Yeah, I think the thing about high blood pressure is it's so sticky, right? So a lot of people, it's so common too. So 47% of adults and maybe even 70% of adults, depending on the definition you use for high blood pressure, have high blood pressure. And because it's one of those conditions that may not cause any symptoms whatsoever, some people will have it and wouldn't know it. So it is estimated that 1 in 3 people that have high blood pressure don't even know that they have it. So as you know, blood pressure is the vital sign. That's something that is always checked when you go into any kind of healthcare facility. And that's the reason, because it's possible to not know that you have it. Unfortunately, even though you don't have symptoms, it can still cause organ damage. So that's the problem, that it can affect the kidneys, the heart, the eyes, and many other organs in the body, even though you have no symptoms while it's doing this.
I know that I check blood pressure in my office, and as a podiatrist, people might find that to be kind of funny. Like, why would a foot doctor care about blood pressure? And then sometimes they walk into the office and their blood pressure is high because they walked into the office. So when is there like when I learned about blood pressure in the past, it was supposed to be a sequence of blood pressures in order to be diagnosed. Is that still the same today? Like, one blood pressure doesn't define you as high blood pressure?
Exactly. And actually, the blood pressures that we check in the office are not the best ones because they tend to be higher than what you will get if you were in your natural, relaxed environment. So ideally, you want to have a series of blood pressure measurements, ideally 2 or more, to be able to, make that diagnosis of high blood pressure. And we can get into, how it's taken and all of that later, but you want, it's not just you check the blood pressure the one time and it's high and then you have high blood pressure. You have to kind of take it in context.
It's so often that patients, my medical assistant does the blood pressure. She has the arm and the wrist blood pressure. And it's so often that patients freak out because it's elevated and they're like, it's never been that high before. And then all of a sudden I become like their primary care doctor. And I'm like, no, it's just a reading. So is there like, do you have a recommendation for medical offices that don't specialize in hypertension? Like, how can we take blood pressures a little bit more accurately, or what can we tell patients?
Yeah, I think the first thing, like in my office, we don't check your blood pressure until you've been seated for about 5 minutes. So I think the way that we triage patients these days is really hard to get an accurate blood pressure measurement because you really need to be relaxed to be able to do that. So having the patient relax, which a lot of times we don't have time to do that, right? And having them, make sure they're positioned correctly with their feet flat on the ground, their back rested, properly, and then their arm at heart level, which means rested on a table that is high enough that it's, their elbow is at heart level. And then checking the blood pressure, and then waiting a minute or two afterwards, and then rechecking it. Ideally, you should check both arms and then take the higher of the higher measurement as the right one. So because that is a tall order, given that they didn't come to you for their blood pressure, if they find that their blood pressure is high, the best thing you can tell them is go ahead and check it at home. Check it at home a couple of times, morning and night, with those instructions. And then if it's still high, they should go see a doctor.
That leads me to the next question I got directly from my patient. The question is, what is an acceptable number for a reading for a 70-year-old African American female? And then what to follow up, what's concerning, and when, and then for me, it's like, when do I send patients to the ER?
Right. So normal blood pressure is 120/80 or less. So pretty much anybody, any adult should be less than that, 120/80 or less. Now, if they already have high blood pressure or they're taking medications for it, we give them a little bit of a leeway. So for a 70-year-old or anybody 65 and older, we'll say your goal will be between 125 to 135 over 90 or less. So now we know you're taking blood pressure medication. We're allowing you to have a little bit of a higher blood pressure than normal. So your goal is a little bit different. Now, if you have risk factors, and there's so many different ones, the goal may vary. So that's why it's not, safely, if you're 120/80 or less, then, if you're 120/80 or less, then you're probably safe, generally speaking, in terms of, blood pressure measurement. But for everybody else, it depends on their risk factors.
Got it.
Yeah.
So
And then
there's no, race is always an issue in medical studies and things like that, like certain, I mean, race is kind of a societal creation, right? But there's also a genetic component too. Is there differences in the genetic components who would get high blood pressure versus another, or does the scale change?
so be African American race is a potential risk factor for blood pressure being high, but the goal doesn't change. So the blood pressure goal is still 120/80. I mean, the normal blood pressure is still 120/80 or less. So, but in terms of the goal doesn't really differ with race, it just differs more with actual, kidney conditions, heart conditions, history of strokes, things like that.
Okay, great.
Yeah.
I'm glad we clarified that. So what are some misconceptions about hypertension that you've seen maybe from patients or even other doctors?
I think one of the biggest thing is misconceptions. Well, before we get into that, the biggest thing is checking that blood pressure accurately. I think that's where we see the biggest mistake. A lot of people will use the wrong size cuff. So the cuff might be too small, and that will falsely elevate the blood pressure, or the cuff might be too big, and that will make the blood pressure seem lower. So I think that's probably getting an accurate measurement is very important, because that determines everything, right? The other thing is people want to know if they're overweight or if they're obese, right? They assume that that's the only thing that drives their blood pressure. So they assume that, okay, if I lose all the weight, then the blood pressure problem will go away. Or if since I'm not obese or overweight, that means I don't have high blood pressure. But a lot of normal weight people still can have high blood pressure too. So it's not only that is one risk factor, being overweight or obese, but that's not the only risk factor. It's just one of the many potential risk factors. The other one I'll say is lifestyle changes can help quite a bit with lowering blood pressure, but sometimes people over depend on that alone. It depends on the person, and depends on how high the blood pressure is. So yes, you can exercise and you can change your diet and all of that. That takes time to work, right? It doesn't happen in 1 month. Typically tends to take 3 to 6 months. But while that's happening, the organs can be damaged. So it's always better to focus on first lowering that blood pressure to a safe level. You can start the lifestyle changes, and then you can always stop medication if needed or reduce medication. So some people think if you start the medication, you're never going to stop it. You're stuck for life. And that's not true. If the lifestyle changes that you decide to do work, then we can always lower or stop your blood pressure medication. And that's a safer way to do it than just, keep doing lifestyle changes for 2 years while your organs are being damaged.
I've never heard of it in that way. Traditional Western medicine, it's always advocated to do medications predominantly. Maybe because we don't trust ourselves to have habitual changes. I don't know what it is, but we do know there is kind of a push to medication over lifestyle. But I think more and more now with the internet and all of the resources online, and now we know what happens at the end stage of disease, we as doctors are pushing more towards lifestyle changes. So what you're saying is you do a combination of both. But you
Exactly.
still need to at least protect the organs with medication and then pursue life changes. Is that right?
Yeah.
So
Yeah,
what
that's
can
my approach.
that sounds good? Okay, I just wanted to, because sometimes I hear it all the time. I don't know if you do, but people think like we get paid to prescribe, and it's
Right.
like, well, shoot, why do I still have medical debt, right? Like, why do I still have debt from school? Like, clearly it's not enough. Maybe I need to keep pushing. No, that's not true. I've not received a single penny for any medication that I prescribed. So that
Exactly.
was a huge misconception for the people I interact with. They think that we're just pill pushers, but there is a huge holistic approach. And I do that on the podiatry side. And I'm really glad to hear that you're also promoting that on your side too.
Yes.
So if I feel like medication, there is such a political drive in prescribing medication in the way of cost. It can be very expensive, right? Because it comes from the company, and then there's like a bunch of middle people in between, the pharmacy that dispenses it, and insurance regulation and things like that. Do you have a resource for people in accessing lifelong medications for more economical cost?
Yes, so I tend to try to find the lowest, wherever they can find it for the lowest price, I try to go. And the thing about blood pressure medicine is because many of them have been around for a long time, there are several pharmacies that will give you a 30-day supply for $4 or less, and a 90-day supply for $10 or less. So you can really get blood pressure medication at affordable prices. A lot of them are pretty affordable.
I didn't know it was that affordable. That's wonderful. But what's even free, what's even cheaper is free is probably walking as exercise, right? And
Yes,
I don't think people really like put the two and two together. They think medication's expensive, but you're like, if you don't have it, you have sickness, and that is even more costly. And I try to tell patients, the most economical thing you can do for your health is walk for 30 minutes every day. I don't know what your advice is on that.
absolutely, absolutely. Walking exercise is one way to actually lower your blood pressure too. So independent of, medication and all of that stuff, you can actually lower your blood pressure by just exercising consistently. So yes, I definitely highly recommend increasing your activity for overall health. It's really, really a powerful way to do that.
Next question. By the way, I really love your answers. They're all like really clear. I understand it. um, who is likely to develop hypertension and why?
Okay, so the way I think about it and the way I explain it to patients is there are two types of risk factors. The first risk factor you don't really have much control over. So that's things like genetics, your age, and your race, right? So it's whatever you came with, that's what you have. And then family history too, you don't have much control over. Now, those ones, we just know that and we work with that. Then there are other risk factors that you do have some control over, like obesity, unhealthy eating, excessive sodium intake, excessive alcohol, and then physical activity. So those things, there are more things on that list that you can change, right? So that's how I mention it to them. So for the things that we can do something about, we try to work on those things as much as possible. And then the things you can't do anything about, is good to know what they are, especially family history. So a lot of people are not aware of what their family history is. And, that is very important because it can affect their health significantly. And it does change what we do with them, depending on what the family history is.
Is the part of family history like a cultural, the way we eat together as a family too, like the social economic factor? Um,
Yeah, it probably is a combination. I think there's definitely a genetic factor there. And especially I tend to see it, especially people that are otherwise healthy, and you wonder how, they don't have anything else that will suggest that they should have high blood pressure. Yet they do. They're healthy, they eat healthy, they do everything right, they exercise, and they still have high blood pressure. In those cases, I think it's definitely more um, genetically based.
we like to blame our parents on stuff. I'll take it. That's fine.
Yeah.
So from a more practical standpoint, patients come in with some anxiety to the office. When should I be concerned that they should then go to the ER for immediate medical attention? Is there a number or some guidelines?
Yeah. So if it's over 180, over 120, especially if you've done all those things in terms of making sure they're relaxed, not laying down, but sitting and relax with their back rested and their arm elevated, and their blood pressure is 180 over 20 or higher, they should just go to the ER, because there are things you could potentially do in the office, but most offices are not set up to do that, get in the labs on time to make sure that they're not having acute kidney failure, for example, things like that. So at that point, most times it's just safer for the patient to go to the emergency room.
What would happen if they didn't? What are the consequences?
So the truth is, most people with that blood pressure probably have had it for a long time. At that, many times they've they have chronic high blood pressure, they just never checked it. And if the more than likely, if especially if they had high blood pressure and they maybe stopped taking their medications for a while, if you started the medication, it would lower by itself in the next, in the next few hours or days. But it's hard to know the difference, especially when you don't see them regularly or you're seeing them for the first time, between those that truly have high blood pressure that is acute, that is causing acute organ damage, and between those people that's their blood pressure the last 2 years anyway. It's not, they don't need to be treated right now the second. So that's the problem. It can be difficult to differentiate. So if they don't go to the emergency room and they happen to be one of those people that have acute are in hypertensive crisis, then they're going to be putting a lot of strain on their heart, and can, which can lead to heart failure. They can be putting a lot of strain on their kidneys, which can lead to kidney failure. They can be putting a lot of strain on their eyes, which can cause, retinopathy and things like that. So it's just in the moment, it's hard to tell for sure where that patient belongs, what category they belong.
Got it. So if I ask my patients to go to the ER, don't be mad at me. I'm just a messenger. I want to have you well protected, okay? Let's just make it clear. I'm not torturing you by waiting in the ER.
Right.
So I imagine you work with a lot of surgeons like myself who request medical clearance or have a risk stratification. What's your opinion about that process? Like, do you call it medical clearance, like they're safe for surgery? Or do you have like a checklist or stratification, like the risk is low? Like that stuff confuses me and it will persist to confuse me because like I'm not really the one asking, it's really anesthesia and it's always anesthesia's fault. I love you all, but really. So can you clarify some of that for me?
Sure, sure. So I call it a pre-op evaluation, right? So I usually never say that they are cleared. I just say that they're either low risk, medium risk, or high risk based on, where they fall, their risk factors and the tests that we've done. I do think it's an important process though. I mean, at least it gets people in to get evaluated, and prior to surgery, it's just better to be safe than sorry, right? Rarely do you find anything significant, but when you do, it can be quite significant. So I think it's a process. It's worth it, to prevent maybe I don't know what the statistics are, but to prevent, even if it's one person, I think it's worth bringing people in to get them evaluated.
Okay, so you call it a pre-operative evaluation. I like that much better because it's almost like when I write it as medical clearance, it's like I'm asking permission, but it's like, but I'm gonna do it anyway. I don't know. Unless you call me and you're like, not a good idea, which, then we have a conversation. So I really
Right.
appreciate that output. What am I saying? I think it's lunchtime is what I'm saying. Anyway, I appreciate you.
Thank you.
I'm curious because you also do family medicine, right?
That's
Do you treat feet in any capacity?
So the most common thing I find, plantar fasciitis, I guess it must be, I probably is maybe one of the most common foot conditions, I'm guessing, because I see it quite a bit. Like that's probably the most common foot condition I manage. Other than that, like a lot of things tend to, I guess we do the microfilament testing for all our diabetic patients, right? But if they do have any neuropathy or just in general, I prefer that they see a podiatrist just to be able to get a thorough evaluation, because that's a big one, right?
Yeah.
But I would say that the most common foot condition is plantar fasciitis, the one I see anyway.
Do you do injections or prescribe prednisone or anything like that for it?
No, no. So if it is at that level, then I would refer. If it's
Okay.
severe, that they do need. So most of what I'll do is make sure they're using a night splint, the exercises, that sort of thing. So if it comes to where they need more intense therapy, then I would be referring them at that point.
So exercise. I think that protocol in itself resolves like 80% of heel pain that I see as well. So it's nice to have another pair of eyes that kind of says the same thing. Because sometimes people like they want to hear different things. Like, there's a special circumstance, but most of the time it's like classic run of the mill plantar fasciitis because you have terrible shoes. I don't know how else to say it.
What it is
So it's
exactly.
good. It's a wonderful partnership to see that. Um, is there anything you'd like to know about podiatry since you got me here?
Sure, sure. So I think one of the things that I'm big on is prevention. So how do people protect their feet? Like, what would you say is the biggest benefit? Like, what can they do to actually protect their feet?
Yeah, protecting your feet, feet are the furthest part from your body, so it gets the least amount of attention. And most people that I end up seeing who could have benefited from preventive foot care, they have advanced diabetes, circulation problems, neuropathy. So the best thing I think that anyone can do before we get to that stage is just being aware. So prevention is awareness, knowing where your feet are, what they look like, if there are moles or unusual skin lesions or calluses, have that evaluated professionally rather than self-treating. So I always tell my
Mhm.
patients, just because it's available to buy at the store doesn't make it safe. So often people are buying like medicated corn pads, thinking they're treating a corn or a wart when it's not that. And then they end up damaging their skin, and then they're self-treating, and then they're doing all these things that end up making their condition much worse when it could have just been one visit to solve that one problem. So just because you can purchase it without a prescription doesn't make it safe. It still requires proper diagnosis and then supervision for maintenance and care.
Yeah, I agree. That makes a lot of sense. I could see that happening.
It happens a lot.
Yeah. Another question I have, what should people be looking for when they're buying shoes?
Oh, here, I'll show you. I don't know if you can see my shoe. I'm the worst example. Okay, so these shoes are
Okay.
loafers, are not good shoes in the sense that they're not designed for walking. They're perfect for office work where I'm sitting down most of the time and I can just get up and sit down as I feel comfortable, but they're not designed to walk more than past your mailbox. So if they fold in half and they twist easily and they don't have any kind of arch cushion, then they're not really meant for walking long distances. And I was just in Disneyland a couple months ago, and everyone had flip-flops, sandals or flip-flops, or like, cute dress shoes that had no support. Those are
Mm,
terrible shoes. They're good for business, but bad for your feet. So I tell
right.
people when it comes to shoes, it really depends on your activity. Like the shoes you wear to rock climbing is going to be way different than the shoes you're going to wear to go walking around at Disneyland. But if you're just looking for everyday types of shoes, make sure they can't fold in half easily at the arch level. They have a decent amount of cushion in the shoes, and they don't twist. Like you can't wring them out like a towel. And that goes
Okay.
for quality issues. And then not just the quality of shoes, but how old are your shoes? I mean, how many of us can say we have a pair of shoes in our closet right now that's older than 5 years? Right. So we're guilty. It looks good. It still looks good on the outside, but the actual durability of the material on the inside, it degrades with time. Just like an old rubber band, that elasticity you lose when it gets all crusty and dusty in your closet somewhere and you find it, it falls apart. Shoes can do the same. So I
Mm.
recommend just checking your inventory. That shoes should be around no older than a year if it was something you wear like on the regular.
Oh, that's great to know. Okay. Yeah, that's really good information. Thank you.
But I bet like we have heels that we probably only wear once in a blue moon. They're probably
Exactly.
bad, but those are sitting shoes. So, I'm
Right.
sitting in them anyway. No big deal. We know their feet are going to hurt afterwards. It's fine.
Right.
Anticipated. Well,
Right.
I think we're going to wrap it up here because I don't want to take any more of your time. But I wanted to know parting words, something, a quote you like, you want people to follow, and then where can people find you?
Absolutely. So one thing I'll say that is most helpful for people's health is finding a consistent doctor they can follow up with. So that will be my parting advice. Find a consistent doctor who can help you connect the dots. I can be found at easily in touch primarycare.com. So that's INTOUCH in touch primarycare.com.
I also wanted to touch on, because you brought it up, consistency in your medical care. And you have a direct care practice, is that right?
That's right.
Can you spend like a minute or two talking about what that is and why that's valuable to people?
Yeah, absolutely. I think direct primary care or direct care in general is it's a wonderful way to take care of people because it allows that flexibility and convenience and the personal relationship in taking care of people that many other traditional practices don't have. So consistency in care is what can help to prevent medical conditions. So that when you see the same doctor over and over again, it helps the doctor a lot because each visit you put in a piece of the puzzle together. And so that's how we can best take care of you when we have that opportunity to see you, spend time with you over time. So with the direct care model, a lot of us can spend, 30 minutes to an hour with each patient. Patients can reach us in between visits. My patients can text, call, email me in between visits and do video visits if needed. So that easy access to care when they actually need it makes a huge difference. And then if they lose their insurance or they change jobs or whatever, it doesn't affect that because it's membership. So they're able to really truly build a personal relationship with a doctor without the fear of losing their doctor over time, and with someone consistently that can connect the dots over time, excuse me, for them.
I really love that. I have a bias with direct care. I do think I have a higher quality relationship with patients as well. And patients might be concerned about going membership versus using their insurance. In your case, can you still use the patient's insurance for like labs or imaging or other things?
Absolutely. So the membership fee is only covers everything done in the office, but if they do labs, imaging, medications, whatever else they need outside of the office, they can certainly use their insurance for it. So they're getting the best of both worlds, I think, because they have a personal doctor that can pay attention to them, and then they can still use their insurance, if they do have it.
Awesome. So you said people can find you at intouchprimarycare.com. Are you on Instagram or Facebook too?
I am. My Instagram and Facebook handles are the same. It's at In Touch Primary. So just at In Touch Primary.
Great. Well, thank you so much for your time. I stole 2 minutes from you. I hope you get it right back. And
No
we'll catch
problem.
you.
Awesome.
Thanks for tuning in, everyone. And I will see you next Tuesday. Take care.
Bye.